Hi, class. This is the first lecture on Chapter 10, Fluency Disorders. So, fluency is one of those words that we use for multiple kind of related, sometimes unrelated meanings in English because English is kind of crazy. But in this case, fluency is a term used to characterize the flow of speech during conversation. Fluent speech has an appropriate rate, an appropriate rhythm. It's smooth and effortless and sometimes automatic. Disfluent speech is characterized by speech behaviors that disrupt that ongoing fluent forward motion of speech. So things like inappropriate pausing, interjections or excessive use of interjections, revisions of message. These behaviors disrupt rate and rhythm. They disrupt the smoothness, the effortlessness, the automaticity of speech. Speech is considered disordered when there's an unusually high rate of disfluent moments that are getting in the way of that flow of communication. Things that are inappropriate for the person's age and for their cultural and linguistic background, including dialect. And I know that that seems a really odd thing to be talking about when we're talking about fluency of speech, but there are some language groups, some culture groups, for example, that use a lot of pausing, a lot of silences within their very typical speech patterns. So we want to, always keep that in mind. Formal definitions of disfluency include not only the presence of those lost my place already, the presence of disturbances in that ongoing flow of speech, but also include the fact that those things present a disturbance to social communication, to academic or occupational performance or achievement. True fluency disorders are constrained to speech and communication and do not involve language functioning. Someone who is disfluent can also have a language impairment, but having a language impairment does not cause a true disorder of fluency. Can having a language impairment cause some disruptions in fluency? Yes, it can, but language disorders in and of themselves do not cause fluency disorders. So, linguistic features such as the use of complex syntax in spoken communication or the use of unfamiliar vocabulary, they can impact that fluent forward flow of speech. But having a disfluent moment because of a complex language feature does not imply language disorder, nor does it imply fluency disorder. So notice that at this point in the thus far in the lecture, we're about 3.5 minutes in. I have not yet used the word stuttering, and there's a good reason for that, because typical speech, non-disordered speech in the area of fluency, will have moments of disfluency. I have already had multiple moments of disfluency in this past 4 minutes. Moments of disfluency are typical. They are in everybody's speech. They're in almost all unrehearsed speech. That is not a fluency disorder. So your textbook says, and I'm quoting now, speech disfluencies are the core features or primary characteristics of a fluency disorder. In other words, those disfluent moments, and we'll describe different types of those in a moment, are the primary characteristics of disorder. I hope to challenge your thinking about that a bit today. For a number of reasons, but let's talk about what those core features are. So, descriptors of disfluent moments. Most typically, we think of repetitions, prolongations, and blocks. Okay. A repetition is when a single sound, like the initial sound of a word, a syllable, so either an initial syllable of a word or a single syllable word, or an entire word, sometimes a phrase, are repeated several times to the point of interrupting the flow of speech. A prolongation is when a single sound, again, usually it's the initial sound of a word, but not always, a single sound is held much longer than it normally would be held. And then a block is when airflow and articulatory movement completely stop during production of a sound. Now, if you've never heard someone in a block, I want to show you what it's like so you can see that it's different from a prolongation. So I'm going to use the word stop in my example. So if I were to do a prolongation in stop, it might sound like this. Stop. Okay. If I'm going to do a block on the word stop or the initial sound of stop, it may sound more like this. Stop. Okay. The airflow was stopped. The articulatory movement had been initiated. You could see my teeth together. I had started the movement for that sound, but then everything froze. Everything stopped, including airflow. Okay, so that's repetition, prolongation, and block. Those are core features. Stuttering, or a disorder of fluency, almost always, not always, but almost always also includes secondary features. Secondary features are behaviors, either physical or linguistic or psychological behaviors, that result from the individual's efforts to promote fluent speech. They are meant to disrupt a moment of disfluency. So these emerge in a person in response to that stuttering moment. So common secondary features are things like eye blinks or lip tremors, head jerks. Some of the linguistic or speaking behaviors that we refer to as secondary features are things like the overuse of fillers or interjections. So the overuse of things like pauses, and then word changes. So I want to say the word hamburger. I know I'm going to stutter on that H sound. So instead, I'm going to say taco. So word changes. Also, the negative feelings. So these are the more psychological secondary features, the negative feelings, the negative attitudes that reflect an emotional reaction to this moment of disfluency. And this is where I want to challenge that notion that I said at the beginning, that the primary feature of fluency disorder are the core behaviors. So let me tell you about a couple of presenters at a fluency conference. In fact, the Cal State Fullerton Fluency Conference, it's held every year in the fall. It should be this month coming. Yeah, it should be right about now. But COVID, right? So in the fall of 2010, at the Fullerton Fluency Conference, there were two speakers. These are two gentlemen who are the experts, or at least at that time, but still are considered the experts in the area of fluency. The first was Dr. Scott Yarus, who is currently an SLP professor at Michigan State University. At the time he was speaking, he was an associate professor at the University of Pittsburgh. He was also at that time director of the Stuttering Center of Western Pennsylvania. And then the second speaker was Dr. Barry Guitar, who was at that time, I'm not sure where he is currently, but he was professor supervisor at University of Vermont. I would suspect he is still there and or retired at this point. And what they pointed out, they both discussed this during their presentation, is that a fluency disorder, what is truly marks the issue as disorder, is what the person does to avoid stuttering. So that stuttering is just one way that people talk. And I'll come back to that when we're talking about therapy a bit. It's just one way that people talk, that they asserted in their talk that the severity of the disorder is better measured by the client's feelings of loss of control, they stated that that surface behavior, the repetitions, the prolongations, the blocks, those aren't the true disabling factor of this. The true level of disorder is better measured by the person's reaction to either the anticipation of those those core behaviors, or their just actual reaction to that underlying feeling of loss of control. And that if we want to help a client change the way they stutter, we have to help them change their reaction to those feelings of loss of control. And that has been, for me personally, that has been a revolutionary way of thinking about treatment when it comes to working with people who stutter, which is the next point of my lecture. I try very hard, we try very hard within our field to use person-forward language. And I'm sure it's something that you've heard referenced now in other courses, not just in our field, but in other courses as well. So instead of saying a stutterer, we're going to say a person who stutters, just like we would say a person who has autism, or a person with a language disorder, or a person with, name the physical handicap. This is an attitude shift, and it's a very good attitude shift. It defines the word stutterer or autistic defines a person, as opposed to saying a person who stutters, which is a description of their speech pattern, not necessarily not a way to define them. Stutterer does not define a person. They are a person first, which is why we call it person forward or person first language. So just a couple other terms. We've talked about these, I think, once or twice before, but we'll talk about it in this chapter and in the next chapter. Prevalence and incidence. So prevalence is the number of people who currently have a condition. So if we were to take a survey of, let's say, the entire student body at Cal State Fullerton, and we asked how many of you currently identify yourself as a person who stutter, that number we come up with would be the prevalence. Incidence is the frequency with which something appears or is reported in the population within a given period of time. Now, incidence can be measured across different periods of time. Usually we're talking about it within a given year, although in the book and in many of the cases that we'll discuss in terms of fluency or voice, we're going to report incidence across a lifetime. So the number here is how many people, let's go back to the student body at Cal State Fullerton. How many of you feel like you have ever identified yourself as a person who stuttered? So slightly different than you've identified yourself as that today, or you have at some point in your lifetime. So now talking about the population in general, prevalence of fluency disorders is about 1 in 100. So 1% of the population would say, today, I identify myself as a person who stutters. Whereas incidence is 5 in 100, or 5% of the population report that at some time in their lifetime, they would have or do still identify themselves as a person who stutters. And we'll talk about why there's a big difference in those numbers in a moment. Stuttering or fluency disorders affect children most between the ages of 2 to 10. And for the vast majority of clients who are identified as someone who stutters, that is when their stuttering began. For the vast majority of them, it actually began between the ages of 2 and 5, but it affects children most between the ages of 2 and 10. Again, sorry, gentlemen, more boys than girls will be identified as people who stutter. So let's talk about recovery from stuttering very briefly here, not therapy, but just the term recovery. The majority of people who identify as having stuttered at some time in their lifetime do recover, either on their own or with some level of intervention. And of course, we're going to have terms for that here in a moment. That is why there's such a big difference between those prevalence and incidence numbers, because most people recover. So there is assisted recovery. This is kind of a duh moment. This is exactly what it sounds like. This is recovery that occurs in conjunction with some kind of intervention or treatment. And then there's unassisted recovery. So it's either completely spontaneous recovery, or it's, if we're talking about an adult, we would call it self-managed recovery. So recovery without any kind of treatment. Now, there's an argument in our field. Thankfully, this argument is going away, but I will say when I was sitting in your chairs and up until maybe even 10, 15 years ago, there was really a big disagreement. Argument's a really strong word, but disagreement in our field that because of that evidence for spontaneous recovery, intervention should not be provided to very young children who exhibit disfluencies, because we know that a good number of them are going to have spontaneous recovery. But we do know from ongoing research in the field that 25 to 50% of children who exhibit disfluencies do not recover spontaneously. There's also plenty of research that indicates that treatment in childhood is much more effective than treatment in adolescence or adulthood. So intervention in childhood, even if it's age 2, 3, 4, 5, may prevent a fluency disorder from becoming a lifelong issue. So another piece of that is it's important to remember that the vast majority of children who spontaneously recover never seek treatment. So they are not the kids that we are super aware of. So when a child is referred to us as an early childhood intervention team, or referred to a doctor, it's more likely that they are not showing signs of spontaneous recovery, that they've been now exhibiting disfluencies for a period of a few weeks, maybe even a few months. And it's important that we provide intervention of some kind. And we're going to talk about what that intervention could look like for a very young child, I think in our next video. So, classification of fluency disorders. We're going to classify by etiology. So you remember etiology means cause. The first cause or the first type is developmental fluency disorders. So these are those that emerge in childhood, typically between the ages of 2 and 5, and they have no known cause. Now, we do know there's so much research that goes on. We always are trying to identify cause in things like fluency disorders and autism and those things that we just don't have a genetic link to. And there is research that shows that there is probably some neurological involvement in stuttering. There's plenty of research that shows it tends to run in families. So we know that there is probably some genetic link, but it, again, still not completely identified. So this developmental disorder that emerges between ages 2 and 5 may last for several months, or it may last for several years, or even into a lifetime. Usually the onset, not usually, always, if we're calling it developmental, the onset is very gradual. It cannot be attributed to any specific circumstance, occurrence, event. The longer it persists, the less the likelihood of spontaneous recovery or self-correction, which is now back to my previous point of if the parent, if it has persisted to the point that a parent is making a referral, we best help intervene in that somehow. Most children go through periods of normal disfluency. I can tell you out of my now 4 grandchildren, one of them certainly went through a period of disfluency, and mom and dad were super concerned. Grandma, me, of course I was concerned, but I wasn't going to let mom and dad know I was concerned because I know the statistics, right? So I kept reassuring them about those statistics. And sure enough, completely recovered, no issue at all, no intervention at all, other than me giving mom and dad some suggestions about how they can model good fluency, we'll get to that when we get to the what parents can do part, but I did that for them. That's probably not why it went away, but it did. So it's a very normal part of the preschool years. Oh, gotta log back in. Hang on, guys. Okay. What distinguishes those normal disfluencies from developmental stuttering is the percentage of and the type of disfluency in spontaneous speech. So normal disfluencies will contain things like part word repetitions, single syllable word repetitions, maybe even initial sound repetitions. So this is the little, 2 to 5 year old that says, I want another cookie, or let's go. Okay, those are normal. Now, if that occurs with a super high percentage every time they have an utterance, that's a red flag. But that's those simple kind of non-stressful word repetitions or single syllable repetitions. Other normal disfluencies, okay, we're still within the range of normal here, not disordered, include things like the use of interjections, the interjections. They will include some revisions, so starting to say one thing and then changing your mind and saying something different. There can be multi-syllabic word repetitions or phrase repetitions, all with under this umbrella of what is normal. The most common kind of normal disfluency is interjection. And I think I may have mentioned this to you once before. I don't know if this is the chapter I always mention it, but there is an interjection that didn't start with your generation. It probably started with your parents' generation, and that is the word like. Using the word like in like every other phrase, like, when you're talking and like you keep putting the word like in there. I want you to imagine being a person who is new to the English language and trying to discern meaning when the word like is interjected in almost every sentence. That's my soapbox. I will get off of it now, because we're not going to keep talking about this. But it is interjection in and of itself is the most common type of disfluency. And you can hear that I use them all the time. I said, I say, I can tell you when I was in graduate school and doing my first clinics, I used the word okay a lot. And it was a way of relieving the stress, the tension, the anxiety. I would throw in the word okay, and it got pointed out to me by my supervisor right away. So that was all normal disfluencies. We all do them. Now, if we do them every single utterance, then they can become problematic. Now, when do they become disordered, or what are the disfluencies that are the red flags that this is disorder? Well, they are all of the same things that I mentioned, those part word, single syllable word, initial sound, interjections, revisions. All of that is also carried over to the realm of disordered fluency, but with the addition of those prolongations, the blocks, and the secondary features or secondary symptoms, the things like eye blinks or jaw tension, head jerks, the negative attitudes. Those, once we start seeing those, we know we are in the realm of disorder. So again, still talking about developmental stuttering. How does it look, or how does it change throughout the lifetime? So in preschoolers with a fluency disorder, if it is a true fluency disorder between the ages of 2 and 5, you will see those core behaviors of repetition, prolongation. That's the hallmark, really, that we've moved from what is normal disfluency to a true disorder of fluency. So prolongations, maybe some blocking. Preschoolers, not as often, but maybe some blocking. there will be the beginnings of secondary behaviors. These little people are starting to have negative reactions and or physical reactions to those disfluent moments. So they'll have the beginnings of negative feelings. If you ask them, tell me about how you talk. What do you think about how you talk? You're likely to hear things like, I don't talk good, or I don't like the way I talk. They will also perhaps have those secondary symptoms of eye blinks or some body movement in reaction to that moment of stuttering. And usually those are an attempt to get out of it. So let me stop and talk about those for just a minute before we move on to school-age children. People develop secondary symptoms because initially they work for them. So a person may get blocked or have a prolongation on a sound, and they find that if they blink through it, it goes away. They get through it. So they try it again and it works a second time. And, by the time they've done it 3 or 4 times, it becomes part of the disfluent moment and it no longer works to get them out of it, but now they're still doing it. So, for example, I had a little girl on my caseload. I think she was in first grade when I first saw her. She'd moved in from another school. And by that time, she was definitely an established stutterer, a person who stutters. There we go. And lots of prolongations, lots of blocks, and lots of secondary features. So she would do things like clap. She'd get stuck in a block and she'd clap, so she's exerting some force in her body. She would bounce up and down in her chair. Sometimes she would even stand up and jump because at some point it worked for her. But now when she'd talk, it would be this series of talking and clapping and bouncing and jumping. And so what we had to work on first, and we'll talk about why when we get to treatment, is getting rid of those secondary symptoms. And I'll tell you more about her when we get to that point. But just know that those secondary features, the physical features especially, are there because they did help at some point for someone to get out of a block. I'll put in my plug here again for the movie The King's Speech. If you have not watched The King's Speech, I'd like to fail you in this class. I'm kidding. I wouldn't do that. But I would love for you to watch that movie. I'm not going to make it as an assignment. But if y'all have any time and you haven't seen it during Thanksgiving week when we're off, and I know that people will probably give you assignments to work on then, but if you have time, it's an Academy Award winner. How can you go wrong with that? But it's a great speech, and you will see just some great examples of all of these disfluencies. You'll also see the therapist. Remember, this was happening in the 30s, probably 1930s, before we had done a lot of the research that we know now. You'll see him actually introduce a couple secondary behaviors to his client, to the king, to help him get out of a stuttering moment, some of which I agree with, some of which I don't. So anyway, there's my plug for watching the movie The King's Speech. Okay, let's move on to school-age children. So school-age children, these are kids now who've stuttered probably for several years. They exhibit all of those same core disfluencies, including prolongations and blocks, so also the repetitions. Blocks are becoming increasingly prevalent and longer in their disfluent moments. The secondary behaviors are